output or inadequate intravascular volume. And then you have got a large group of miscellaneous causes. So this is the categorization: neurogenic, vasodepressor, failure of sympathetic, reduced cardiac output or inadequate intravascular volume, and miscellaneous causes. What is this? Neurocardiogenic. That's the first group. We commonly call it as vasovagal. So there is vaso and there is vagal. They are due to inhibition of sympathetic tone from central mechanisms, like you see suddenly blood or you get sudden pain. So central mechanisms inhibit the sympathetic tone due to various causes. It may be physical severe pain or psychological, seeing blood, murder, depressing situations. And this causes suppression of the cardiac neural receptors. You know, there are so many receptors in the blood vessels, heart, arch of aorta, and this psychic stimuli suppresses the cardiac neural receptors. And there is excessive vagal tone. That's a vasovagal. So vagal tone, when it is vascular, because cardiac neural receptors are influenced by the stimuli that the person has faced, and it increases the vagal tone. When the vagal tone is increased, there is bradycardia. So vasovagal syncope is characterized by bradycardia and syncope. That's vasovagal. Next, failure of sympathetic innervation. So there will be vasodilatation, peripheral vasodilatation. When there is sympathetic innervation failure, that's the second group. There will be vasodilatation. So this doesn't present like the vasovagal where there is bradycardia. Here it is orthostatic hypotension. So failure of sympathetic innervation presents as orthostatic hypotension. Next group is cardiac. Most of the cardiac conditions, including cardiac failure, all can produce. So you have commonly the stroke Adam attacks, and you have got valvular disease, exertional syncope, you have been taught, and ischemic heart disease, cardiomyopathies, and advanced cardiac failure. So these are common, and we have got miscellaneous that comes under psychogenic syncopes, seizure, syncopes mimicking seizures, or metabolic drugs. All these come under miscellaneous group. So what is pre-syncope? So we saw syncope as a sudden loss of consciousness and immediate coming back to normal without sequelae. What is pre-syncope? The symptoms that precede syncope are called pre-syncope. So these symptoms could include extreme lightheadedness, visual sensations such as tunnel vision or graying out, and variable degrees of altered consciousness without complete loss of consciousness. So they are unable to concentrate, they take more time to react, they repeat questions, but apparently appear conscious and confused. And pre-syncope could progress to syncope, or it could abort without syncope. So this is pre-syncope. So what is the pathophysiology? So as you know, consciousness requires ongoing cerebral perfusion. We know the consciousness has got two components. One is the content, next is the depth. Content of consciousness is what is embedded in pre-syncope, and depth is embedded in syncope. So content is in the hemispheres, depth is in the brainstem. So consciousness requires ongoing cerebral perfusion, which in turn requires the proper functioning of a set of coordinated physiological mechanisms. So cerebral perfusion has to be maintained, and that happens through several physiological well-balanced mechanisms. So we have got baroreceptors in the carotid sinus, aortic arch, cardiac ventricular, that is a neurocardiogenic. All the systems in the human body function in balance. The Nadaraja's dance, they function in balance. So baroreceptors in the carotid sinus, aortic arch, cardiac ventricular walls, and intrathoracic vessels. All these sense the alterations in the pressure and the chemical environment, and the signals are transmitted from these receptors by the glossopharyngeal and the vagal nerves. And these nerves carry this to the nucleus of the tractus solitarius in the brainstem. So all the baroreceptors in the vascular tree goes through the glossopharyngeal nerve and the vagus and enters in the nucleus of the tractus solitarius and the brainstem. and it can act on the sympathetic or parasympathetic. And when the sympathetic is facilitated, there is bradycardia and hypotension. Parasympathetic is facilitated, there is bradycardia and hypotension. And when the sympathetic outflow is impaired, there is vasodilatation and orthostatic hypotension. And while assuming erect posture, there is excessive pooling of blood, which is prevented by peripheral in the peripheral heart, that is in the muscles, that is prevented by peripheral vasoconstriction, release of vasopressin, and mechanical effect of the muscle pump compressing the capacitance veins in the calf. That is why it is called peripheral heart. And there are prodromal symptoms occur when mean blood pressure is less than 60 millimeters of mercury. And when the mean blood pressure is less than 50 millimeters of mercury, there is decrease in the cerebral function. And mean arterial pressure, what do we understand by the mean arterial pressure? That is the average blood pressure during a cardiac cycle. And it is a measure of the pressure that drives blood throughout the body. So mean arterial pressure is the average blood pressure during a cardiac cycle, and it is a measure of the pressure that drives blood throughout the body. So we have got many complex formulas which needs more evaluation tools also, but that I am not going to. I am more interested in clinical approach. So you can do this with a simple formula. Mean arterial pressure is equal to diastolic blood pressure plus 1/3 into systolic blood pressure minus diastolic blood pressure. So there are some reflexes in maintaining this perfusion. One is the Bisolde-Jarisch reflex. The traditional model of neurally mediated syncope involves the Bisolde-Jarisch reflex. It is a paradoxical aberration of the normal response to orthosis. Normal response to orthosis, we saw that there is peripheral vasoconstriction, which acts as a peripheral heart. There is release of neurotransmitters. So venous return is enhanced. So the paradoxical aberration of this normal response happens with this reflex. So Bisolde-Jarisch reflex, there is excessive venous pooling. We saw that the venous pooling is prevented by sympathetics producing vasoconstriction acting on the peripheral heart, that is the calf muscle. So when this reflex comes, there is excessive venous pooling. Therefore, there is decreased preload and ventricular filling. And therefore, the heart works more to pump. So there is a hypercontractile left ventricle. That leads to activation of the baroreceptors and cardiac ventricular wall receptors. And this leads to signals which are transmitted by the vagus nerve. And when the vagus is facilitated, there is bradycardia and hypotension. And when sympathetic is inhibited, there is vasodilatation. So this is Bisolde-Jarisch reflex, which is the opposite of what is normally happening. So the Bisolde-Jarisch reflex is a cardiopulmonary reflex in which the parasympathetic innervation, crucial to regulate heart rate, systemic vasomotor tone, and respiration, is activated and promotes bradycardia, hypotension, and apnea. Other reflexes are Bainbridge reflex, which responds to increased blood volume, whereas the baroreceptor reflex responds to changes in arterial blood pressure. So baroreceptor reflex is for pressure changes, Bainbridge reflex is for volume changes, and Bisolde-Jarisch reflex responds to mechanical and chemical stimuli acting on the left ventricular wall. And susceptible individuals show greater reduction in cerebral flow and greater dilatation of forearm vasculature in response to hypocapnia as compared to normal. So some people are susceptible than normal who have got some differences in the pathomechanical control, where there is peripheral vasodilatation to hypocapnia. And insular cortex, which is a center concerned with interoceptive awareness, visceral states associated with emotional experience, and autonomic control. We saw that the vasovagal syncope is mediated by emotional experience, which leads to autonomic disequilibrium. So this interoceptive awareness center is the insular cortex. So now we will see the group of symptoms. We have seen syncope, pre-syncope, and briefly the pathomechanisms. Elaborate not possible, only template. So prodromal symptoms can be due to autonomic instability or due to cerebral hypoperfusion. Autonomic instability leads to lightheadedness, nausea, warm feeling, chill, facial pallor, clammy skin, yawning or sighing, tachypnea, mydriasis, tinnitus, increased peristalsis, salivation, restlessness, and fecal urgency. Whereas cerebral hypoperfusion leads to lightheadedness again, inability to focus mentally, general weakness, muffled hearing, color vision desaturation, dimming of vision, tunnel vision, and swaying posture. This occurs gradually from 30 seconds to several minutes prior to the syncope. So it gives you time. Retinal ischemia is responsible for dimness of the peripheral visual field and loss of color vision. ARAS inhibition affects the depth of consciousness. If abrupt with no prodrome, why it is important to recognize these prodromes? So prodromes are a feature of vasovagal syncope or sympathetic failure or neurological causes, whereas if prodrome is not there, it's very important. If the prodrome is not there and there is an abrupt syncope, think of a cardiac cause. That is the importance of knowing these prodromes. So a clinical topic. So if the patient comes with a syncope and there is no prodrome, most likely it is a cardiac cause. Then resembling a seizure. So many times we put patients unnecessarily on anticonvulsants when there is a syncope. So what are the features which can resemble a seizure in a syncope? One is the myoclonic jerks. It is reported in 12% to 90% in some studies and consists of multifocal arrhythmic jerks involving proximal and distal muscles, whereas in a seizure, it is stiffness or a rhythmic jerk which produces an in-phase movement because it passes through neural pathways. Seizures pass through neural pathways. So there is an in-phase movement, whereas this is out-of-phase multifocal jerks. It is believed to result from inadequate brainstem perfusion. And next is opisthotonus. That can also resemble extensor spasm of seizures. So our head turning is occasionally seen lasting 1 to 15 seconds. So head turning and opisthotonus can also be seen in pure syncope. It need not be diagnosed as seizure. The eyes usually remain open and initially deviate upwards. So eyes open always doesn't mean seizure and the eyes deviate upwards. And downbeat nystagmus can happen due to vestibular disinhibition as a consequence of cerebellar hypoperfusion. And breathing usually continues during unconsciousness and may appear shallow, slow, or deep. So all these are not indicating that it is not a syncope. All these can happen in a syncope. And rarely apnea in patients who were asystolic for more than 30 seconds. And the pulse pressure diminishes. Peripheral pulses briefly become undetectable. And transient focal neurological deficit can happen. And urinary incontinence can happen. And immediately following a syncope, there is headache. So what are all the causes? So these features does not give the label of a seizure to the patient. So then causes vascular, it can be reflex, neurocardiogenic, that is vasovagal or vasodepressor syncope, situational, certain situations like cough syncope, micturition syncope, defecation syncope. These are situational. Then carotid sinus hypersensitivity, glossopharyngeal neuralgias, and atypical types of reflex syncopes. Then we have got the orthostatic syncope due to supposing there is an internal hemorrhage. So that is volume dip. Orthostatic syncope can happen due to volume depletion, due to internal hemorrhage, autonomic insufficiency, and pharmacological agents or venous pooling. So this is orthostatic syncope due to autonomic insufficiency causing postural hypotension, volume depletion, drugs and venous pooling. The next is the cardiac causes, structural and obstructive. Structural causes may be aortic stenosis, hypertrophic cardiomyopathy, cardiac tamponade, myocardial infarction, pulmonary embolism, pulmonary hypertension, arrhythmias like bradyarrhythmias and tachyarrhythmias, and malfunctioning pacemakers. So what is the age-wise distribution? The vasovagal happens in younger age group, and next atypical forms happen little more older. Situational is usually in the third decade, and carotid sinus syncope is beyond 40 year, fourth decade. So early is vasovagal, late is carotid sinus syncope, and in between comes the situational and the atypical forms. And autonomic dysfunction syndromes present as orthostatic hypotension. Then you can have postural orthostatic tachycardia syndromes, and you have got chronic fatigue syndrome. So these are some autonomic dysfunction related. They are postulated. Chronic fatigue syndrome also autonomic dysfunction is postulated. So these all can present with syncope at times. So what is a typical vasovagal syncope? It's the commonest one, the classical form, onset at a young age, usually in the first decade, and otherwise they are healthy. And typical vasovagal prodrome triggers, and that I told the central triggers like seeing blood, frightening situation, pain, and it affects about 50% of all individuals, and 70% of the population is predisposed for this, and there are strong stressors which precipitate, and there is no genetic basis, no evidence of autonomic involvement or hormonal disorders, and there is low risk of trauma as they get time and they can sit down or fall down, and frequent spontaneous disappearances in advanced age. So as the person grows old, this spontaneously goes away. And atypical vasovagal syncope, atypical or non-classical. So unlike the younger age, sometimes it can come in older age. And patients with cardiovascular or neurological disorder, and that is called atypical vasovagal. And presentation without prodrome, classical vasovagal as prodrome. So presentation without prodrome and atypical triggers, not the classical pain, frightening experience, but simple soft triggers. And often diagnosed only after a positive head-up tilt test. So it's difficult to diagnose when it comes later age group, and overlap with carotid sinus syndrome, overlaps with situational syncope. So vasovagal and micturition syncope can coexist, and overlap with orthostatic hypotension or other dysautonomic symptoms, and high risk of trauma, whereas the classical vasovagal, it gives prodrome, it gives time, so trauma is less. And sometimes progressively it increases, whereas the classical vasovagal decreases and disappears. Next is situational syncope, exertional syncopes in athletes after exertion. So that is one exertional syncope. And micturition syncope, middle-aged men taking vasodilators or after drinking alcohol evening hours without recalled premonitory symptoms, while passing urine in the standing posture, they faint and they can develop head injuries. Then other multifactorial, maybe orthostasis, vasodilatation due to alcohol, activation of mechanoreceptors in the bladder wall during sudden emptying, and increased intrathoracic pressure. All these might contribute to the micturition syncope. Cough syncope, increased intrathoracic and intracranial pressure. And then you have got a postprandial syndrome. So increased intrathoracic, intracranial pressure results in cough syncope. And postprandial syncope, blood pressure maintenance after a meal depends on the interaction of sympathetic baroreceptors and vasoactive peptides released to compensate for the increase in the bowel blood volume. Following food, the bowel blood volume increases. That is why after a heavy meal, we feel sleepy. And generally in Tamil, it used to be told that a person who eats too much cannot be a scholar, because always the blood will be pumped to the stomach and for digestion, that blood available to the brain matter is less. So multiple mechanisms compensate from preventing a postprandial syncope to compensate for the increased bowel blood volume. Then when they fail, you get a postprandial syncope. Then after syncope, intrathoracic pressure increases, vasovagal reflexes become activated, and possible neuroendocrine effects triggered by the limbic circuits of the laughter. Then you have got a deglutition syncope. It is very rare, and stimulation of stress-sensitive mechanoreceptors in the esophagus, vagal reflex, so inhibits the cardiac conduction system and produces syncope. And facial flushing and palpitation may precede loss of consciousness. And many have an underlying condition such as an esophageal spasm, esophageal stricture, or achalasia cardia, which makes them vulnerable for deglutition syncope. Then sleep syncope, mostly middle-aged women waking from sleep with either abdominal discomfort or urge to defecate is followed by syncope. Some patients remember nightmares before the episode, and most patients also have daytime episodes which sound like a vasovagal in nature. So tilt table testing is frequently positive. So sleep syncope is characterized by waking up from sleep with some autonomic reflexes and syncope, and they can have vasovagal-like episodes, and tilt table test will be positive. Next is carotid sinus syncope. Carotid sinus massage for 5 seconds leads to a ventricular pause of 3 to 5 seconds, or fall in the systolic blood pressure of 50 millimeters of mercury, a rare variant of neurocardiogenic syncope. And this accounts for 1% of syncope in the later age group, after the age of 40, resulting from pressure at the carotid sinus, like shaving, using a tight collar, or quick turning of the head. Next is orthostatic hypotension. It's a diagnosis of exclusion. A fall of more than 20 millimeters of systolic and 10 millimeters of diastolic blood pressure within 2 minutes of standing is called orthostatic hypotension. And this can happen with decreased intravascular volume when diuretics are used, or it can be due to vasodilator drugs, primary autonomic insufficiency or failure like Scheidegger syndrome, Parkinsonism, and others, and secondary autonomic insufficiency like diabetes mellitus and amyloidosis, alcohol consumption which impairs vasoconstriction, and aging, attenuation of vestibulosympathetic reflex. Medication accounts for 5 to 15% of syncopal events. The mechanisms can be orthostatic or cardiotoxicity. So vasoactive medications like alpha and beta blockers, calcium blockers, nitrates, antihypertensive medication, diuretics, and erectile dysfunction treatment drugs like sildenafil, and medications affecting conduction like antiarrhythmics, calcium blockers, beta blockers, and digoxin, and medications which alter the QT intervals like antiarrhythmics, antiemetics, antipsychotics, and antidepressants. Next comes the cardiac causes. Cardiac arrhythmias. This is the most common, cannot be diagnosed easily since most are paroxysmal and infrequent. And there is an abrupt change in the heart rate, fall in the blood pressure, causing transient loss of consciousness. And common causes are sinus bradycardia, AV nodal block, sustained ventricular tachycardia, supraventricular tachycardia, and structural cardiac or cardiopulmonary disease like inadequate cardiac output, and cardiac valvular disease, hypertrophic cardiomyopathy, acute MI, acute aortic dissection, and pericardial tamponade. And blood flow obstruction, aortic stenosis, cardiomyopathy, pulmonary stenosis, idiopathic pulmonary artery hypertension, atrial myxoma, and pulmonary embolism. And chronotropic incompetence, that is inability to achieve desired heart rate for a particular frequency of exertion. That also is one cause for exertional syncope. We call it as chronotropic incompetence. And the differential diagnosis, posterior circulation TIAs, drop attacks. Posterior circulation TIA can sometimes, when there is a top of the basilar syndrome, crus cerebri ischemia, they can buckle and fall. That can resemble a syncope, or they can really develop a syncope due to brainstem ischemia. And drop attack is an sudden loss of postural tone with immediate righting and retained consciousness. So drop attacks or retained consciousness, these are common in elderly, very difficult to treat as the real pathomechanism is unknown. Cataplexy is part of narcolepsy cataplexy syndrome, postprandial, exerting, high carbohydrate meal, they suddenly buckle and fall, retain consciousness. There can be associated narcolepsy, sleep paralysis, and hypnagogic hallucinations. Then we have got psychogenic syncopes and seizures which mimic syncopes. What is psychogenic? Young female mostly, happens in the presence of others. Eyes are usually closed, or they can have a flickering movement that we call it as Rosenbach sign, and it can be induced by suggestion, lasts longer, and there are no signs. Then how to differentiate seizure and syncope? So that is convulsive syncope. I mentioned there can be multifocal myoclonic jerks which are out of phase movements. So it can be mistaken. Somebody will tell my body shaken and we think it is seizures. So how to differentiate a convulsive syncope from an epileptic seizure? The myoclonus follows the loss of consciousness in syncope, whereas in epileptic seizure, it is part of the phenomena. The eye deviation is upward in convulsive syncope, whereas it is mostly lateral in epileptic seizures. And myoclonic rhythm is arrhythmic, whereas in epilepsy, it is in phase along the neural pathways. And multifocal jerks briefly involving bilateral proximal and distal muscle is common in convulsive syncope, whereas unilateral and asymmetrical always indicates seizures. And myoclonus duration is 1 to 15 seconds in convulsive syncope. It is little more in epileptic seizures. And urinary incontinence can occur in both conditions, more common with seizures. And postictal fatigue, but no confusion in syncope, but postictal confusion happens in seizures. Automatisms are absent in syncope. Cyanotic phase is absent in syncope. Tongue bite is absent in syncope, whereas all these can be present in seizures. So it's very important to ask clinical questions in thorough detail and never try to supplement with an EEG, because normal people, 30% of normal people can have abnormal EEG and patients with seizures can have normal EEG. Either way it is possible. So just as I started, I want to insist that supplementing laboratory for everything will result in lot of wrong diagnosis, extreme cost for medical treatment, and sustain this temporary body unnecessarily, causing trouble to our loved ones. That should not happen. So learn clinical medicine so that you make treatment and sustenance of life user-friendly. So you have got investigations suggested by the European Society guidelines. One is the exact semiology. I have explained all the clinical semiology. So get some eyewitness and tell them to describe the semiology. Ask about the posture. What was the activity to know whether it is situational? Any precipitating features like alcohol, drugs, and any predisposing features like seeing painful environment. Then associated nausea, vomiting, abdominal discomfort, feeling of cold, sweating, aura, pain in the neck or shoulders, blurred vision and dizziness. And careful history, thorough clinical examination, including looking for orthostatic blood pressure and ECG are simple tools which will help us in sorting out a good number of patients. Then semiology, slumping, pallor, cyanosis, flushing, the duration of unconsciousness, which I have described between syncope and seizure, the type of breathing, is the movement tonic, clonic, or minimal myoclonus? Is there any automatism? Is there any tongue biting? What about nausea, vomiting, sweating, feeling of cold, confusion, muscle aches, skin color, injury, chest pain, palpitations, urinary and fecal incontinence. These are the questions you should ask and elicit. Then ask for family history of sudden death. It can be cardiac, some aberrant conducting pathways may be there. And history of previous heart disease, Parkinsonism, epilepsy, narcolepsy, metabolic disorders like diabetes, and the drugs that the patient is taking. Then, what are all the points in favor of cardiac cause? Cardiac cause, age is older, male gender, heart disease, brief prodrome or no prodrome. There can be palpitation, syncope during exertion, syncope in the supine position, and few episodes only. They don't have very frequent episodes. And abnormal cardiac examination, family history of inheritable conditions or premature cardiac death, and presence of non-congenital heart disease. These points favor a cardiac cause. Non-cardiac, younger age group, no known heart disease, syncope only in the standing position, and positional change from supine or sitting or standing producing the syncope, presence of prodrome, presence of specific triggers like dehydration, pain, distress, they all point to vasovagal, and situational like cough, laugh, micturition, defecation, deglutition, and frequent recurrence is common in non-cardiac. Focus on thorough head-to-foot examination and examine all systems, because syncope is only a symptom, not a disease of one system. Then risk prediction scores in evaluation of syncope. So when somebody comes with one syncope, it's an alarming situation. So they will ask how often it is going to recur. When we really, some situation we do not know the cause and we cannot answer these questions. So there are some guidelines primarily designed to predict patients at risk for short-term serious outcomes, and it helps in decisions. OSIL scale, observation, epidemiological Sulla syncope score. So if you have an abnormal ECG, history of cardiovascular disease, absence of prodrome, age more than 65. If these four features are there, 1 year mortality increases with an increased number of risk factors from 0 for no risk to 57% for 4 risk. If all these 4 are there, at the end of 1 year, risk of death is about 57%. So you can use this simple score. Look at the abnormal ECG, history of heart disease, absence of prodrome, age more than 65. You can give them a poor prognosis. And this is S of SR or San Francisco syncope rule. So this is again another risk prediction score, slightly modified. Abnormal ECG, history of heart failure, history of dyspnea, hematocrit less than 30%, systolic blood pressure less than 90 millimeters, predictive of short-term serious outcomes within 7 days of the initial visit. So 96% sensitivity and sensitivity. So this is short-term, that is 1 year. The previous score is 1 year risk of death becomes 57%. Here it is 1 week risk of recurrence and complications. So risk prediction scores in evaluation of syncope. We have got evaluation of guidelines in syncope study score. This is another score. So palpitation before the syncope, you give 4 points. Abnormal ECG and heart disease, 3. Syncope during effort, 3. Syncope while supine, 2. Autonomic prodrome, 1. Predisposing or precipitating factors, 1. So this scoring is used, and a score from +4 to -1 is assigned to each variable. We have seen that. And a score of 3 identified cardiac syncope with a very good sensitivity. So use palpitation, abnormal ECG, syncope during effort, syncope while supine, autonomic prodrome, and precipitating factors. These 6 parameters are used to score, and with a 0 to 4 point scale. And if 3 scores are identified, it is a cardiac syncope. So the selection of a given diagnostic test. After that, we have now seen only the clinical and simple ECG parameters. And the selection of a given diagnostic test after the initial history, physical examination, and baseline ECG is a clinical decision based on the patient's clinical presentation, risk stratification, and a clear understanding of diagnostic and prognostic value of any further testing. So when I have been taught by my teacher, you order a test if it will either help the patient or help science. That is for research purpose. So it should help the patient positively or it should help in a research project. Otherwise, unnecessarily, you should not order all expensive investigations, which is very, very frightening to see the world progressing. So Syncope additional evaluation and diagnosis involves initial evaluation, history, physical examination, and ECG. That is mandatory for everyone. And if the initial evaluation is clear, just wait. And if the initial evaluation is unclear, cat on the wall like parameters, then you have to do targeted blood testing in some patients based on the clinical indication. And initial evaluation suggests neurogenic orthostatic hypotension, look for autonomic function test. And if it suggests reflex syncope, use the tilt table test. If it suggests cardiovascular anomaly, do complete cardiac evaluation. So based on the unclear areas, select only the needed test and then you can decide, and you can do the stress testing and you can do the MRI, CT, all those things are supplementary if it is needed. Then blood testing recommendation. Targeted blood tests are reasonable in the evaluation of selected patients with syncope identified on the basis of clinical assessment from history, physical examination, and ECG. So brain natriuretic peptide and high sensitive troponin measurement is not recommended for everybody. It gives uncertain information. Routine and comprehensive laboratory testing is also not useful. So the most useful test in a patient with a syncope are history and examination. You can do simple carotid sinus massage, but it can be dangerous or threatening to the patient and bystanders. You can use tilt table testing, and you have got higher implantable loop recorders for rhythm changes. They are useful. The less useful tests are ATP test, eyeball compression test, Valsalva maneuver, and external loop recorders, echocardiography, and minimal or no values Holter monitoring, CT, MRI, and EEG. So 2009 European Society of Cardiology guidelines recommended the following testing strategy. So carotid sinus massage. It is in patients more than 40 years, but you have to be very careful. Bystanders can become frightened. Sometimes patient can develop complications. So in this era, you should be cautious, but it is a very cheap, cost-effective test in an appropriate case. Then echocardiogram, immediate electrocardiogram monitoring when there is a suspicion of arrhythmic syncope, immediate electrocardiogram. Then orthostatic challenge. Then tilt table test, it's an orthostatic. I will not be elaborating this because each one is a topic by itself. Tilt table test is an orthostatic stress test, well established as a provocative maneuver in the diagnosis of neurally mediated syncope. And the Heart Rhythm Society recommends tilt table testing test when differentiating between a convulsive syncope and an epilepsy. So in a convulsive syncope, tilt table test will be positive. In an epileptic syncope, it will be negative. And when establishing a diagnosis of pseudo syncope, where nothing will be positive. And when evaluating patients with suspected neurally mediated syncope, he have no clear diagnostic features where tilt table test can be positive. Assess the susceptibility of a vasovagal response to a postural change from a supine to an upright position. Tilt table angle of 70 degrees for 30 to 40 minutes will provide optimum yield. A positive response is defined as inducible pre-syncope or syncope associated with hypotension with or without bradycardia. and very rarely asystole. The hemodynamic response to the tilt maneuver determines whether there is a cardio-inhibitory, vasodepressor, or a mixed response. So, document the hemodynamic changes, the blood pressure changes, the heart rate changes, respiratory changes, and then draw conclusions. So, then we have got the methods, you have got Westminster protocol, and you can also use, that's a passive, you don't do any chemical agents, or you can use a low dose isoproteinerol challenge, or you can use a nitroglycerin challenge, or you can use a clomipramine challenge. These are other methods of increasing the results in a tilt table testing. So positive response is classical neurocardiogenic response, an abrupt drop in the blood pressure, heart rate, or both. And next, that is a classical neurocardiogenic response. Dysautonomic response, a gradual progressive fall in the blood pressure with relatively little change in the heart rate. That is autonomic, orthostatic hypotension. And postural tachycardia response, 30 beats per minute increase in the heart rate in the absence of hypotension, but in association with symptoms such as lightheadedness or syncope during the first 10 minutes of the baseline tilt. Then cerebral syncope, syncope in the absence of systemic hypotension concomitant with, say, intense cerebral vasoconstriction and cerebral hypoxia. There is no hypotension, but there is cerebral vasoconstriction. That is cerebral syncope. Psychogenic patients experience loss of consciousness in the absence of any observable change in the heart rate, blood pressure, EEG, or transcranial Doppler recording. Then classical neurocardiogenic syncope. We have gone through this. So what is the role of EEG? We routinely do it because it is easily available, but there is only a limited role except when during the attack. And EEG, neurally mediated syncope, shows a slowing of background followed by high amplitude delta activity that may progress to flattening consistent with cerebral hypoperfusion. So, and a classical finding is called slow, flat, slow pattern. Slow, flat, slow pattern, that is normal background alpha attenuates and progresses to slow activity of increasing amplitude. So, high amplitude slow waves. First is high amplitude slow waves, then disappearance of the slow wave with a flat EEG tracing. The duration of which depends on the length of the time that cerebral perfusion is interrupted, followed by again appearance of high amplitude slow waves. So this is otherwise called rhythmic intermittent delta activity. So slow, flat, slow. That is the pattern you will see in neurally mediated syncope. You may or may not exclude or include a seizure with a EEG. Then carotid sinus massage. Your dominant cardio inhibitory form. What are the responses we see? One is the dominant cardio inhibitory form. There is asystole for more than 3 seconds with reproduction of spontaneous symptoms. And carotid sinus massage after atropine does not produce additional information. So that is dominant cardio inhibitory. There can be asystole for 3 seconds. 3 seconds. Mixed form, there is asystole for more than 3 seconds and fall in the systolic blood pressure more than 50 millimeters of mercury with reproduction of spontaneous symptoms. After atropine, there is mild symptoms due to fall in the blood pressure more than 50 millimeters of mercury. Next is a dominant vasodepressor form. There is reproduction of the spontaneous symptoms due to systolic blood pressure fall more than 50 millimeters of mercury without asystole. And carotid sinus massage after atropine remains unchanged. So that is the dominant vasodepressor where there is hypotension only. Whereas in the other two, there is also asystole with or without hypotension. Then ATP or the adenosine test, This also not recommended for everybody. In selected cases, you can use. The test requires the rapid injection of 20 milligram bolus of ATP or adenosine during the ECG monitoring. The induction of an atrioventricular block with ventricular asystole lasting more than 6 seconds or the induction of an AV block lasting more than 10 seconds is considered abnormal with adenosine triphosphate, and abnormal response in 28% of patients with syncope of unknown cause. So it is useful that way. And adenosine sensitive patients, older with female predominance, shorter history of syncope, and higher prevalence of systemic hypertension. So these people tend to show a positive test. And low adenosine plasma levels are predictive factors for a positive ATP test, while high adenosine plasma levels are a predictive factor for a positive TIL test. So basal adenosine level, if it is low, that person is likely to show a positive ATP test. And if they have a high adenosine level, they are likely to show a positive TIL table test. Then exercise testing, you have interpreted the development of a tachycardia mediated morbid type 2 second degree or third degree atrioventricular block during exercise. So exercise can induce a type 2 heart block. That is one information gone by exercise testing. And the development of hypotension bradycardia, syncope immediately after exercise is diagnostic of a reflex syncope. And development of hypotension and syncope or pre-syncope with exercise but without bradycardia suggests autonomic failure as a cause of syncope. Then other cardiac tests are Holter monitor, trans-telephonic monitor, external loop recorder, patch recorder, which is commonly used, and mobile cardiac output telemetry. Then treatment depends on the cause. Avoid the triggers what are identified and always use non-pharmacological methods. And next, when indicated, pharmacological therapy, and when indicated, device therapy. So non-pharmacological, recognize the premonitory symptoms of syncope and go and lie down so that we don't fall and injure ourselves. Increasing dietary salt intake to at least 10 grams per day. Discontinue potentially contributing medications like alpha antagonists, diuretics, vasodilators. Avoid sudden standing up. Avoid standing motionless for a long time. The compression garments can be used, and it should be actually not in the calf alone. It should be up to the thigh or include the abdomen also. That will be useful. Then the leg muscle pump can be considered as a second heart and is capable of translocating blood against a substantial pressure gradient. That's why it's a peripheral heart. And moreover, that use skeletal muscle pumping or heel raises. That's plantar flexion exercise. That will contract the calf muscle. Rising on the toes using calf muscle to raise heels off the floor, and repeated knee flexion, that is marching in place. This will enhance a peripheral pump. Bending, it's an useful maneuver for patients with autonomic failure. The beneficial effects can be ascribed to pronounced abdominal compression, squeezes the blood from the compliance planic venous pool towards the heart, lowering the head to the heart, shortens the hydrostatic column between the heart and the brain. So when you are bent, the distance between the heart and the brain becomes reduced. So, and the brain instantaneously by 25 to 30 centimeters, corresponding to a hydrostatic pressure increase of 15 to 20 millimeters of mercury in the mean blood pressure. Then it's a cocktail party posture, mechanical compression of veins in the legs. So this leg crossing, squatting, and crash positions. So these are practiced routinely. They reduce the orthostatic hypotension in autonomic failure. Then you have got counter pressure maneuvers. These kind of postures can be used during stressful situations. Then acute water ingestion is recommended in patients with syncope caused by neurogenic orthostatic hypotension for temporary relief. The pressure effect of water is most likely sympathetically driven, with a peak effect occurring 30 minutes after the injection of more than 240 ml. The additional benefit is seen with more than 480 ml. The presence of glucose or salt may reduce this effect. Generally, we tend to add sugar and salt, but that is not really recommended and not intended for routine use, but it is used for short-term use. Then you have got Midodrine. It is reasonable in patients with recurrent vasovagal syncope and neurogenic orthostatic hypotension with no history of hypertension, heart failure, or urinary tension. A prodrug that is metabolized to desglamidodrine, peripherally active alpha agonist used to ameliorate the reduction in the peripheral sympathetic neural outflow. Dose is 2.5 to 10 milligram very frequently and may use up to 40 milligram per day. In a meta-analysis, it is associated with 43% reduction in syncope recurrence. Then fludrocortisone is relatively safer. It's a mineralocorticoid. Dose is 0.1 to 0.2 milligram per kg per day to up to 1 milligram. It can produce hypokalemia and sometimes hypertension, edema, headache, and rarely immunosuppressive. Other drugs used are beta blockers, decrease cardiodepressor response proven to be beneficial in people more than 42 years, and paroxetine, it's a serotonin reuptake inhibitor. Bupropion acts through norepinephrine and dopamine reuptake inhibition. Clonidine in autonomic failure patients. Pyridostigmine, it is useful in postural orthostatic hypotension. Octreotides, planktonic vasoconstriction. Scopolamine and disopramide, vagolytic. And theophylline, central and peripheral adrenergic agonist. Then you have got head up tilt on bed, elastic support for the limbs, then diet with the salt, and aerobic exercises, fludrocortisone, methylphenidate, midodrine, clonidine, yohimpine, ephedrine, fluoxetine, erythropoietin, pindolol, and desmopressin. And impedance threshold device, the role of permanent cardiac pacing in vasovagal syncope is controversial based on the observation that 1/3 of the patients have symptomatic bradycardia or asystole during tilt table testing or during spontaneously occurring syncope. This is recommended. So I have briefly gone through a template approach to syncope, and this should be used only as a template to build your knowledge on syncope. Any questions? Within this limited coverage, I can answer. Any questions are there?
Ma'am, there are no questions yet, so we can wait for 5 minutes if you wish to. Then
Okay.
end this.
Otherwise, if there are questions coming, you can
Yes, ma'am, I'll let you know.
forward.
Yes, ma'am, sure.
And if anybody is wanting any specific topic also, you can inform now. I am only choosing the topics.
Okay, ma'am.
The students wanting any topic, I can do it. Thank you. Should we close?
Ma'am, no one is asking question right now, so
Okay.
I think it is
Okay.
okay to
Thank
end.
you.
Thank you so much, ma'am, for the nice session.